So what am I talking about with this type 2 inflammation? Well, so we kind of categorize subtypes of asthma into T2 high or Th2 high and T2 low. So on the left side of the screen here, this would be both allergic and just eosinophilic type 2 high inflammation. And so the classic way we think about this is kind of allergic inflammation. And so in this scenario, allergens are sampled by dendritic cells. They're presented to Th2 cells. And so that's why this is called T2 inflammation, is that Th2 cells were initially discovered to be the primary drivers of this type of inflammation. And once you stimulate these Th2 cells, they produce other interleukins like interleukin 4, interleukin 13, interleukin 5 that can drive both the allergic response and increase eosinophil development, activity, maturation. On the other hand, you can still have type 2 inflammation even in the absence of allergies. And so things like pollution, microbes, other things that irritate the airway can cause the respiratory epithelium to also release a group of cytokines called alarmins. That includes interleukin 33, 25, and TSLP. And when that happens, they can activate these innate lymphoid type 2 cells. They're called that because they're part of the innate immune system in that they don't have a specific receptor like a T cell does. But when they're activated, they can release the same cytokine profile, like interleukin 5, for example, which then draws in eosinophils and creates T2 type inflammation even in the absence of allergic disease. So both of these are considered T2 high asthma. On the right hand side here, we have neutrophilic asthma and possigranular asthma. These are the T2 low asthma population, and this is predominantly Th1 and Th17 cells that promote neutrophilic inflammation. Possigranular, there's not really a predominant cell type that is involved in that, but they still have an asthma picture. These two groups are notoriously less responsive to the typical therapies that we use for T2 high asthma. And so why do we care about all this inflammation? Well, higher exhaled nitric oxide levels are associated with increased, more accelerated lung function decline in patients with moderate to severe asthma, regardless of whether they're on optimal treatment or not. And in patients with adult patients with newly diagnosed asthma, there was a study that showed that using an ENO cutoff of 57 parts per billion, so again above that 50 limit, and also BMI had, those patients had accelerated lung function. And so what we're worried about, and this is what I talk to patients about when they have an elevated ENO, is airway remodeling. And so you can tell, what I tell patients is if you have inflammation in your lungs, your body is going to try to heal that, but your body heals it by scarring it. And it's not exactly scar tissue, but it is laying down fibrin. And so that's the pictures that we're looking at on the left. So the top slide here is a picture of a normal airway. So we see a normal respiratory epithelium, a thin basement membrane. The blue is all fibrin deposition, and then the muscular layer. And we can see in the asthmatic airway a much thicker basement membrane. We have a lot more blue in this picture, so a lot more fibrin deposition, and the muscular layer is much thicker in the asthmatic airway compared to the normal airway. And so you pile all these things on top of each other, that leads to increased airway obstruction. And you can see evidence of airway remodeling in kids as young as 3 years old if they have persistent wheezing.